Good morning, good afternoon, good evening, wherever you are. Welcome to this MDS roundtable, which is run by Blood Cancers Today. It's a true pleasure to be with you today. My name is Amer Zeidan. I'm an associate professor of medicine at Yale University. And today we will be covering a lot of the exciting developments in the field of MDS. The last couple of years have seen important approvals and some important changes to the risk stratification as well as the classification of MDS. And to debate all of these new aspects, I'm joined today by three of my colleagues. All of them are top experts in MDS.
Hi, my name is David Swoboda. I'm the Director of Leukemia at Tampa General Cancer Institute.
I'm Jamie Koprivnikar. I'm at the John Theurer Cancer Center in Hackensack, New Jersey.
I'm Sangeetha Venugopal, Assistant Professor of Medicine in the Division of Hematology at University of Miami Sylvester Cancer Center.
Welcome to all of you. Jamie, for your practice, the drug Luspatercept has now been approved in the frontline setting in August or September 2023. Has your practice changed in the frontline setting, and how do you think about using ESA versus Luspatercept versus lenalidomide in the frontline management of anemia and lower risk MDS?
So I think absolutely the data from the COMMANDS trial is practice changing. So of course, for patients who are suffering from transfusion-dependent anemia who have 5Q minus lower risk MDS, of course I'm still going to use lenalidomide. In that particular group of patients, they were after all excluded from participation on COMMANDS. So we really do not necessarily have the data to support the use of Luspatercept in that subset of patients. Otherwise, if I have a patient who would have been eligible for the COMMANDS trial, meaning EPO level less than 500, certainly I'm starting those individuals off with Luspatercept. I do think, in addition to the, nearly double the response rate as compared to weekly epoetin alpha and the longer duration of response, epoetin alpha was dosed weekly as part of COMMANDS, whereas Luspatercept was dosed every 3 weeks. And so I find it very difficult and burdensome for my patients to come into clinic every week. So to be able to offer them an every 3-week option, I think just adds to their quality of life. Now, I think the population of patients who we still don't know what to do for are those who present with an EPO level of greater than 500. I don't think we have any great options for those patients that are currently, available to us, although I do think we're going to be seeing the approval of some agents shortly that may be appropriate for that group of patients with the EPO greater than 500.